The UK clinical trials scene has influenced clinical trial design and clinical practice now for easily 50 years, initially through the Medical Research Council funding, which is why frequently our international colleagues refer to the research activity in the UK as being the MRC. But in actual fact, the MRC hasn't funded myeloma clinical trials now for about 20 years. Cancer Research UK has funded our clinical trials programme in the late phase portfolio, and the early phase portfolio has been funded by Myeloma UK, initially through their own clinical trials network, and then latterly through the CARP early trials programme that I lead from Leeds University. And basically we have been developing and delivering particularly late phase studies that have influenced clinical practice. For example, we produced data that showed the efficacy of consolidating induction therapy with an autologous stem cell transplant, which was the Myeloma VII trial. Myeloma IX looked at comparing a novel agent regimen, which at the time was CTD, compared to infusional chemotherapy, and demonstrated that using chemotherapy wasn't necessary. And then you get to Myeloma XI, which was the biggest frontline clinical trial globally to ever be delivered, with over 4,000 patients across the intensive and non-intensive arms. And that gave a very sizable and robust data set. For example, looking at the efficacy of lenalidomide maintenance in both intensive and non-intensive treatment pathways, as well as the impact of MRD and the relationship to lenalidomide treatment. And then we look at salvage transplants. Myeloma X was the only study globally that gave randomized phase 3 evidence to support the use of a salvage transplant compared to a non-transplant consolidation strategy. Now, the treatment elements of that study, because they're over a decade old, are not as relevant to modern day, but the principle of a transplant versus no transplant in the salvage setting was demonstrated by that study. In the follow-on study, Myeloma XII, which is nearing completion at the moment, will take it further one stage to look at the role of augmenting the transplant conditioning and whether in the salvage setting, is there a reason to be giving post-transplant maintenance. And then we move to the current phase 3 trials, which are using biomarkers to define whether those biomarkers are predictive or just prognostic. The first biomarker is MRD, and that's the study being run by Kui Yong and Mark Cook, and that will be looking to use MRD responses post-transplant and transplant-eligible patients to define how we deliver treatment. For those who are negative, it's about de-escalation, and those who are positive, it's about looking about escalating and using non-cross-resistant novel agents in that setting. In the transplant non-eligible population, we are looking at using the IMWG frailty score, which we know is a prognostic biomarker, but as yet no one has proven whether it has predictive biomarker potential. And that's what Myeloma XIV is going to be about. It will look to see whether upfront dose modification in accordance with our IMWG frailty score will actually allow for improved survivorship through the early period of treatment. It will look at the treatment tolerability, and will look at overall event-free survival and overall survival compared to a control arm where all patients will be given standard dosing and having dose reductions implemented in accordance with toxicity, which is a standard way that we deal with things. And then we've got our early phase trial work that includes Rakesh Popat's PROMISE, which is an umbrella platform study using the BCMA-directed therapy and a number of different combinations, and that's going to be in relapsed refractory disease. And then we actually will be looking at a T-cell engager in post-transplant MRD positive patients.